Good day, everyone, and welcome to today's webinar entitled The Role of Technology in Healthcare Today, a Forecast of What's to Come. My name is Mark Haglund, and I'm Editor-in-Chief at Healthcare Innovation. Today's program is sponsored by Nuance. Thank you so much to our friends at Nuance and to you in our audience for giving us your time and attention today. Before we get started, I have just a few housekeeping details to share. To submit a question, please use the Q&A box to the left of your video window at any time. You do not have to wait until the end of the program. For technical issues, please press F5 to refresh. And if that doesn't work, you can submit a question with your issue through the Q&A panel. Finally, join our webinar conversation on Twitter. You can tweet using the hashtag #HILiveWebinar. At this time, it's my pleasure to introduce our speakers for today's program. They are, first, Dr. Anthony Mazzarelli, who is co-president of Cooper University Healthcare and Associate Dean of Clinical Affairs for Cooper Medical School of Rowan University. Prior to his current role, Dr. Mazzarelli served as Cooper's Chief Physician Executive, where he saw the physician practice. He is a practicing emergency medicine physician. And he is joined today by Diana Knoll, who is Executive Vice President and General Manager of the Nuance Healthcare business. Dr. Mazzarelli and Diana Knoll will now engage in a discussion, and you will see me again at the end when we conduct Q&A. Dr. Mazzarelli and Diana, the floor is yours. Thank you.
All right. Well, thank you so much, Mark. It is great to be here, as always, talking about both the challenges that exist in the industry, but all of the opportunities. And I think they're actually a bit more balanced now, but we'll hear from Dr. Mazzarelli and get his thoughts on it. So Dr. Mazzarelli, you know, there are lots of challenges, but if we really start the discussion on some of the biggest challenges that your organization is facing, I think we would all just love to hear about what's top of mind in that area for you.
Sure. Well, first of all, Mark, thank you for that introduction. Diana, thank you for both of you for having me here. So look, I think most CEOs right now would say what I'm saying, which is the thing that's keeping me up at night, and I think most of us up at night, is the labor market and what's happening in the labor market, and the extraordinary expenses that we're putting out, and really what at its core is a war for talent, a war that's not going to go away anytime soon, whether there's inflation or no inflation. And we are in that war in trying to recruit talent at all levels, at every position in the health system. And we're not only competing with other health systems, we're competing with other industries, because most of what we do, not all of it, but most of what we do, you have to be there, you have to show up. So we're competing with other jobs where people can do remotely. And so we know that also there's an increase in burnout in those that are healthcare workers. Something like a third of healthcare workers have considered leaving healthcare within the next year. That's exacerbated by the fact that we already know that we're going to be shorthanded with physicians over the next several years. So that labor market overall was keeping us up at night almost pre-pandemic, because this was sort of coming, and then the pandemic became an accelerant for what was already a problem.
Yeah, so we're having shortages. You're having a war on talent, you know, and then you've got burnout, right?
War for talent. My competitors, I will frame it as a war on talent, but it's a war to try to attract talent.
Yeah. So really pretty amazing. And the burnout, right? I mean, they kind of work together hand in hand, because if you have all the shortages, the doctors, the nurses, the clinical care, the staff that's actually still providing the service is probably feeling extremely overwhelmed. And as you mentioned, we've seen the same stats. We've seen that we're going to have shortages in the hundreds of thousands in just a couple of years. And maybe what I would do is I would double click. You know, we've asked at times, do you have a thought around how much this is kind of costing you? Like when you lose a doctor or you lose a nurse, what is actually the hard kind of cost associated with that, so that we can really appreciate what that does to you?
Sure, there's data out there on this. So I'm not just going to give you data from my organization. This is data across the board that has been published. So for a physician, it's about $500,000 to $1 million when you think about the complete turnover, because it's the recruitment costs, it's the offboarding, it's the onboarding, it's the ramp up until they're as productive as someone that leaves. And that totals, in at least one study, about $4.6 billion a year. That's just physicians. And so if you think about that issue across every possible type of worker, it's an enormous burden on the U.S. healthcare system, and one that, how do you fill that gap? And you're right, it's a vicious cycle, right? Because we not only do we not have enough people, there's burnout that's causing there to be less people. There's actually physically less people because the birth rate in the country has gone down. And then once you have less people, it makes the job harder, which makes people more likely to feel that depersonalization and like they're not making a difference, and what are essentially the hallmarks of burnout. So it makes it even worse.
Yeah, and I think the other thing that we haven't even talked about yet is, what does that actually do to patient care, right? There's these statistics that have now come up where it says like how long it takes to get into seeing if you're a new patient, like it could take you 6 months, et cetera. And so this whole, how do you view this as sort of the impact on the patient, the breakdown of trust, or just the fact that, people can't get in to see somebody when they need it? I mean, maybe talk a little bit about that as well.
Yeah, I think it hits in three categories, right? So I think there's certainly access problems when you have a talent shortage or you're in times like this. So like you're saying, the lag, the time someone calls to get an appointment to the time they get an appointment ends up being very large. And that lag makes it not only frustrating to patients, but potentially could impact their outcomes if they're not able to get care or the care they want in a certain amount of time. The second thing that ends up happening when you think about, with respect to sort of there's access, has to do with just not having enough of a workforce to provide the quality of care that you want. So if there is a certain workforce that makes things move the fastest, makes things move the most efficiently, is likely to help patients move through the system, whether it's accessing the outpatient or through a hospital or through an OR, that can affect not only the patient's perspective, but also their outcomes. And then lastly, even if you have the people, but if they're burned out, we know that is tied to more patient safety issues, more medical errors. And also, if people are burnt out, they're not leaning into patients and connecting. And when you connect with patients, we know there is a whole host of things that you benefit from, which include outcomes and lowering costs and actually decreasing burnout. We can get to that in detail. But at the end of the day, there's a lot of aspects to how this problem exacerbates outcomes for patients.
Okay. Well, big problem, very big problem from all different angles. This is not going to be something that there'll be a silver bullet to. There's going to be probably lots of things here, and for each piece of this system, and we'll talk a little bit about that. So obviously, coming from a tech company, we're always kind of working, hopefully maniacally focused on what can we do to actually leverage technology. We'll talk about some of the latest things in technology, but start out with the audience. Explain what you're using technology for in terms of addressing this challenge.
Sure. So we think, look, technology interestingly, medical technology is very popular in medicine, right? We do things in the U.S. healthcare system that are done nowhere else. We have cutting edge medical technology. But technology has also been something that has led to the burnout issue. People look at the electronic medical record. They often mistake the fact that our burden with respect to regulatory things and billing things we have to write down as physicians, that's gotten higher just as electronic medical records hit. So people tend to confuse the two. And so there's oftentimes people look at technology as part of the problem. Oh, look, I have so much more to do, so many more clicks. My head's in the EMR more than it used to be in a paper chart. And then at the same time that's happened, we've had this, sort of rise in how accessible it is to get to the chart. With what I mean is this: 30 years ago, the only work you could do at home if you were a physician was to take a phone call or work on the number of charts you could hold under your arm. Well, nowadays, it's ubiquitous. You can get access to that information anywhere. And while that is fantastic, in some respects, I think the electronic medical record, no matter how much people don't like aspects of it because we haven't been able to tame it to use to our advantage, it's saved lives. I mean, we used to not be able to read what physicians wrote. Physician handwriting is still something people talk about as, being known for being poor, right? So we certainly have had quality things improve, but there's this issue that it's been really hard to tame. And I always ask people, when was the last time you had an empty inbox for your email? And very few people can even remember the last time they had an empty inbox. Well, imagine an inbox in which people's lives depend on it. And that's what we have with the electronic medical record. So that's why people kind of are down on it. I think, though, to answer your question, is more technology is the answer to that technology problem. What do I mean by that? Well, we need to offload these administrative burdens that clinicians have, whether they're physicians or nurses or anybody else, to anything we can either automate or supplement so that people can do administrative tasks, don't have to do as many administrative tasks. And I think if you ask physicians, we get paid to do paperwork. We see patients for free. We feel like we get paid to do that paperwork. So if you can lower administrative burden and increase the amount that people can actually spend time talking to patients, that's what people want to do. That's why they go into medicine. You get lots of benefits because leaning into the patients and connecting with them more will improve outcomes, and it also will decrease burnout, and overall it will lower costs. So we are looking at using technology to offload administrative burden of anybody that we can so they can work top of license.
Okay. And that I think that's what has resonated. I know at the recent HIM show, there's a lot of conversation about generative AI and where it can be used. And people are kind of like, well, it shouldn't be used here. It should be used there. And I think your point is, and we've heard the same statistics. We've heard that for every 1 hour of patient care, there's actually 2 hours of administrative tasks. And so there was this, real focus on the way that these leading technologies can help is on the administrative burden. And, administrative burden, of course, we focus in on clinical documentation, but there's also things that have been recently talked about in terms of helping just manage that inbox. If it could just help triage or direct me in the email to where I should focus. If there is things that come in and they were, ask for a prescription refill, it could go here. I've also heard, for example, radiologists say, hey, if it could just help me get the data, the insights from the prior report, so I know what I'm looking. So as you think about technology, and if we were just to do a little bit of a double click, and by the way, we've also seen on the nursing of just, hey, you're doing your rounds, you're putting stuff on sticky notes, and then you've got a handoff to the next nurse on the next shift. Where are you starting in terms of, and
Sure.
By the way, the other thing I heard, which was really interesting, is physicians, clinicians, they need administrative tools just to help their own lives, like knowing what their own. Somebody told me they needed to know like how much vacation time they had left, something like that. So what is the breadth of where you think this administrative burden will be tackled? Well,
I'll answer, you sort of two questions there, right? What are we doing now? And where do I think it's going to be tackled, right?
Yes.
So where we're using it now is in what we do in our partnership with you, with Nuance, which is using the product DAX, Dragon Ambient Experience, using ambient technology that literally listens the patient's consent to it and listens to the conversation between the patient and the doctor. And the doctor doesn't have to worry about taking notes, doesn't have to bury their head in the electronic medical record, and look the patient in the eye, connect with patients. So we could talk about the data of how beneficial that is. And then artificial intelligence writes that note. And that note, so it decreases the thing that we like to do the least, which is paperwork. Now, it's still something the physician signs off on, and it doesn't just transcribe it. It thinks about it, and it puts the things in all the right spots and checks the right boxes and makes sure things are worded in the right way. And so it really is something that 2.0 is what you would think of as transcription or a scribe to really put things everywhere it needs to be. So we saw that as something we wanted to do. At the end of 2020, we formed this, we made this available to all the physicians that we were able to onboard with it, and we're still making it more and more available to people. And as it gets adopted, people are learning how to use it more and more. In fact, for our physicians that use it more than 50% of the time, when they write notes, they've seen a 43% reduction of the time they spent in the EMR. And when I say inbox, I literally mean inbox. There is a separate inbox inside of Epic and Cerner of things you have to handle, like messages. We've seen an incredible increase in patients messaging physicians. That's probably a good thing. They want information, and messaging is easier than trying to make a phone call. But that also increases the burden of messages that you need to respond to. So I can see a future where you use artificial intelligence to do that first draft of what that response is. Not necessarily automatically responded, because you want to make sure things are correct, but supplementing the work and taking a lot of that administrative burden and the cognitive burden off the physicians and nurses and nurse practitioners and physician assistants, so that it's already there to help them respond. And another direction I see this going in is what you talked about, is summarizing. As an emergency medicine physician, if I have a patient who has a very intricate medical history, before I walk in the room, I have to, what we literally call chart surf. I have to surf around the chart to see what are the important areas that I think are going to be important before I walk in and see a very sick patient that I know nothing about. Well, that chart surfing can all be done and use artificial intelligence to gather up the things I might want to know. And so you could see that as another use case. And frankly, I could probably name 5, 6, 7, 8 use cases for how you would use artificial intelligence and technology in the future of healthcare. But for everyone I can name, there's probably 5 that I can't name right now that will actually end up being more predominant than all the ones I'm naming. Because this technology, I'm very optimistic, will change things. And I think it's going to change things for the better.
Well, thank you for that. That is really great. I'm going to probably bridge us into another question. But before I leave this, is there anything that you think is really critical about the way technology is deployed? Like what you talked about, whether you like it or don't, the EHR has done some things. So when you think about how technology has to be deployed for success, what are some of the things that you at Cooper, look for?
So for us, it's about workflow. Technology, you think about what is the right workflow to be as efficient as possible. And then technology is just one component of, people, process, and technology on how you have that correct workflow. And so we don't want to be too over dependent on technology. We don't want to not use technology enough. And I think that's really important. And that's how we think about things. The electronic medical record was rolled out because there were incentives for everyone to switch to electronic medical records. And so it came faster than probably would be an organic introduction in which we could have controlled the way in which we use it. So now we need tools to use this very powerful tool the correct way and sort of tame it to work for us and for patients. And I think that's what some of these technologies will do.
Okay, definitely resonating in terms of workflow, because if you think about, as you said before, sometimes when we initially adopt technology, it's different for us. And that adoption curve is very challenging at times to figure out how do you adjust to the new workflow. And I know you and you and I have even talked about what the evolution is in a person's career to do that. Back to your original point, I am curious, since you have been adopting technology, what kinds of things has it been able to improve relative to the first things we talked about, such as burnout and staffing shortages? Is it a competitive advantage, for example, to people that may be coming out of college in terms of what they want to work in, or just people at the top of their career that want to, what are they looking for in terms of how you kind of position this with Cooper and kind of help socialize it with the rest of the community out there?
Sure. So I answered both, a comment, your first comment and your question. So your first comment was, what have we seen about how we've deployed this out, right? And we saw something very, very interesting that I would have been was totally wrong about, and how I thought when we deployed out this technology, this ambient intelligence technology, the DAX technology. And that typically, and what I've seen in the past, is that when you roll out a new technology, it's the technophiles, the nerds like me, that are going to be the ones that use it the most. And then they sort of adopt it. And over time, it gets adopted by the people who are not the technophiles, right? So there's these early adopters. We actually found almost the opposite, or actually the opposite with respect to this, because it was actually the physicians who were a little more veteran, who never really felt comfortable in the EMR. They grew up in a different environment, that are seeing some of the biggest gains in getting back 2 and 3 hours a night and how they can get into the chart. So I think that's certainly one part of it. Why we did the technology, I think your second question, and if I If I'm not answering the right question, just ask me again.
You're on a roll. You're great.
But how we've used it as a competitive advantage and what I think will happen to the marketplace of kids coming out of college and things like that. So yeah, for us, we see decreasing that administrative burden as a competitive advantage in the marketplace. If we're all having a war for talent and we have a technology that can that we're deploying that others don't, we think there's a real advantage to that, particularly technology we know it has these benefits. I do think when it comes to sort of jobs and how you deploy technology, it's something we have to think about. We have to think about deploying technology in an ethical, correct fashion, and that it doesn't, can't lead to harm. And of course, a lot of people talk about the doomsday aspect of artificial intelligence or how it's going to replace all kinds of jobs. History doesn't really show that that's how this works, right? So if you think about it, we have a tendency to, and it's a Stanford computer scientist in the 60s that said this, we have a tendency to overestimate the impact of technology in the short term and underestimate the technology in the long term. So for instance, I'm sure that people were concerned that like the candle making industry was going to fall apart when lights were made, right? And that the horseshoe industry would fall apart when the car came. And those things did, but other jobs took their place. Nobody thought that there'd be hundreds and thousands of jobs in the cybersecurity area. They more thought about how the internet was going to take away everyone's job by automating and increasing communication. So I think, from the doomsday scenario, we have to control how things work out. And we can always think about reasons why we shouldn't do technology. But I think that history shows that the technology we tend to have a really good skill of figuring out how to have it help us, even though there's a doomsday scenario for every new technology that's ever been developed. And then when it comes to the jobs thing, I mean, it creates new jobs. I think about, the DAX, Dragon Ambient Experience, and how many people are working on DAX. And maybe it takes away from some other career, but it adds to another.
Yeah. Well, I think before we leave technology, we should probably talk about generative AI and the aspects of responsible AI and kind of where we touched on it. And, a lot of people have said, well, you could see like a chat GPT function embedded within the workflow and asking lots of questions. Could it give a differential diagnosis, et cetera, et cetera? Of the things that we've talked about, I mean, where is your opinion? What is your thoughts on the latest? What do you think is good about it? What do you think, to your point, how will it get on this adoption curve and things? What's your organization thinking about this?
So here's the way we think about it. It's the way I think about it, which is generative AI in its current state. If you look at and play around with GPT-4, for instance, or GPT-3, 3.5, what you'll find is that there's two aspects of it. There is how smart it is and how smart it functions, and then how fast it is. With respect to how smart it is, when I think about what I do when I'm seeing patients, is I say it seems to be about as smart as maybe a second or third year medical student. Maybe GPT-4 is more like a fourth year medical student. But its speed is faster than the speed of sound. Like it's almost instantaneous. But that speed can't be mistaken for accuracy. And if I have a fourth year medical student with me, even though the work product is there and it could be really, really good, I still am ultimately responsible for how it's used. And I think the best AI that we see that's out there is AI that's coupled with human intervention. And that's the way you have to use this. Whether you're getting decision support about a differential diagnosis, whether someone's helping you write notes, whether you're gathering information in EMR, you have to make sure you check for accuracy, but it's a huge efficient head start, right? I mean, it's copy and paste didn't destroy creativity, but it would be almost impossible to live without copy and paste now. We have to think about it in those kinds of terms, that we still have to be responsible for our work.
Yes, exactly. I mean, I think about even, whether it's the care that's given to my parents or other members of the family, it wasn't a single caregiver either. It was, multidisciplinary care teams and things. And so if it can bring insights together to help those things, the most complex of cases, but also to help, some of the basic things as well, I think, it really goes back to what we initially talked about. We have such issues with administrative burden, and we're faced with these shortages. We have so many things that we can do to just kind of address that and get ahead of that and, get get us back to physicians having at the tips of their hands what they need, which I think is really where you focused.
Well, you just said something really important, I think, which is about how, when a family member goes in, how many different physicians or how many different care providers they deal with. Medicine is so much more complex than it used to be.
Yeah.
And, in 50, 60, 70 years ago, like, is it you're going to get leeches or penicillin, right? Like there wasn't a lot there. Now there's so much, and that's a good thing that we're getting better and better technology, personalized medicine, smarter with our knowledge base from what's in the biomedical literature, more procedures going to the outpatient setting, more people not need to be admitted. But you have a heart attack now, you're out of the hospital in a day or two, where it used to be you would sit in the hospital for 2 weeks, 3 weeks. And so we really have gotten better, but that knowledge and that body of knowledge means we need decision support. We need assistance. We can't hold it all in our head as physicians. And I think that's really, really important.
Is there anything before we leave this topic, because you also made me think about something we talked about, what it can do for the physicians. I always say there's no patient out there that doesn't want to get better, but oftentimes they're a little overwhelmed when they're in an office visit and they leave and they're like, what was I supposed to do? And, oh, I got there and, well, this prescription's kind of expensive. What do you think it can help once the patient takes over more of their care? Do you see opportunities there?
Sure, absolutely. And I think the idea that patients only get medical advice when they bump into the healthcare system is what's going to end, right? Like, so the only time that you're going to think about your healthcare is when you schedule an appointment, and then you kind of wait till you get in there. Constantly being able to interact in some way where you can ask questions, you can get answers, reminders, just like other things in our life that technology has improved. I think you're going to see that in medicine and well, and it'll really activate patients to be more participants in their care.
Okay. Well, I'm going to turn a little bit differently. I always sort of view it as when we as a vendor, we always say we have to deliver a demonstrable ROI. We have to deliver a true value add. What are the outcomes that your organization is expecting when you think about technology? Hard, soft outcomes. How do you decide on what to do, what not to do when, resources are pretty still scarce in terms of the investment areas that you can go into on these things?
Sure. I mean, in the U.S. healthcare system, particularly for those that provide care, it's a small margin industry, right? So we have to think about where we place those dollars. And where we're going to place dollars are things where there's an ROI, and that ROI can be financial, or that return on investment could also be from a quality perspective. The way that we view the world is that if we can get people connected with patients and they can look them in the eye, they can interact with them, they can really connect. We know the data, there's tons of data out there that it will improve the outcomes of the patients, it will lower total costs, and it'll decrease burnout. So any tool that lowers that administrative burden to do that, we look at the mound of evidence, and I'm happy to go into it, of how it will help with those three things. And we think that's really important. And there's even and you ask, like, well, what metrics do we look at? It's the same metrics. It's all the business metrics we've always ever needed to look at, right? So, how does it affect our bottom line? How does it affect our quality scores, our patient experience scores, our physician engagement scores, our nursing engagement scores, overall team engagement scores? It's the same endpoint. The point is, it's the methodology to get to that endpoint that we think you have to focus on allowing people to connect with patients.
Yeah, I think that is underestimated, the impact of the trust. I have been it's been shared with me in the past how a patient, if they don't feel like there's a trust and they haven't been listened to, they will actually be more likely to drive down the street, see another doctor, see another specialist, ask for third opinions, second opinions, third opinions, which may be fine, but it's not necessarily what you ideally want. You want to develop that relationship and know what the patient wants to do and what the clinician can do to help them, as you said. You have written a lot on this in terms of compassionate care, the ability to show that empathy and that listening. Maybe you could talk a little bit about that and a little bit more of a double click on, what have you actually seen in terms of the research here, the hard research that you've done on it?
Sure. So This idea that we improve outcomes, lower costs, and decrease burnout is the core of compassion science, which is a major area that I've written about with my co-author, Steve Trzeciak. It is a major area of research and what we call our compassion lab here at Cooper. But really, it's not just the research we've done, it's the research we've gathered. We looked at over 250 medical articles and over 1,000 abstracts. So essentially, we reviewed the entire biomedical literature on this, and what we found is astounding. So let's talk first about outcomes, right? So I'll just give you one example. It's amazing that when you have a more compassionate physician, how much more compliant physicians are with taking their medicine. It's been seen in multiple studies. I'll give you one. That when they take a standardized tool that measures compassion and they bucket the physicians to low, medium, and high compassion based on these standardized, validated tools, what they found was they looked at their diabetic patients, and if they had a physician that was on the high compassion side, they had an 80% higher odds of having an optimal glucose, an 80% higher odds of having normal cholesterol levels, and a 41% decrease in having diabetic complications, which is why we control people's sugars in the first place. When I look at the study, one of my favorite studies done at Johns Hopkins on HIV, they asked the patients this question: does your physician know you as a person? And if the answer to that was yes, those patients had a 20% higher odds of having no viral load of HIV because it was in an HIV clinic, and a 33% higher odds that they are actually taking their medicines. This has been shown for mental health, for pain, and no matter what you look at, the outcomes are better when you have that interaction that's increased between those that provide care. It's not just physicians. It can be nurses, anyone else. That connection, there's 22 different mechanisms of way that connection helps improve care. So it's amazing. Now that's outcomes. Let's talk about costs, right? So, the U.S. healthcare system is enormous when it comes to cost, right? If you take just the spending of healthcare in the U.S., it would be the 5th largest economy in the world, right? So hips and knee replacements in the U.S. are the same revenue as the entire movie industry. So it's a huge number. And there's tons of waste in the U.S. healthcare system. There's over $300 billion a year attributable to healthcare that's being paid for patients that could have avoided that if they were adherent to their medications. So there's a whole host of ways that costs are affected. When you practice patient-centered medicine and there's a connection between those that receive care and those that provide it, those patients have a lower total number of charges at the end of the year of healthcare dollars, less likely to have to see specialists, less likely to have tests. So it's amazing what can happen when you can allow people to connect. But we are connecting less. Eyeball time with patients is down, right? And that's what we were talking about in the beginning. But the third and most powerful category that we're talking about is burnout. And when I was in medical school, I was always taught, don't get too close to patients. You get too close to patients and you'll get burned out. Well, if that were true, then the data would show that the higher the compassion of someone who provides care, the higher the burnout. And that's not the case. It turns out the inverse is true. And so really leaning into patients and being able to not do administrative things and really focus on connecting with patients is actually protective of burnout. And so that's why that's a really important aspect of what we're talking about here. In order to do things, we get people back to connecting with patients.
I think the one thing that I take away from some of this conversation too is that sometimes we view the industry as being fairly slow in moving. But when I think about how care has been done in the past and how it has evolved, I actually am much more optimistic and more hopeful, as you said, because the interaction, now we have a lot of different ways and a lot of different choices, and patients, just like consumers, people have grown up now with different technologies and different expectations, and just simply getting a text reminder can have a positive impact versus what may have happened in the past where you had to actually see somebody and you had to sit across from them. I am amazed at my own care teams that have kind of followed up and said, hey, did you follow up and do this? Did you, I noticed, have you taken that prescription I suggested for you, blah, blah, blah. And these things about being able to interface in the way that now is much more practical, I also think is quite intriguing. What is your view about that as well? When you think about this compassion, does it actually have to be always face-to-face?
I don't think it always has to be face-to-face. There's actually an article that came out not that long ago that showed that AI can be even more empathetic than people can be. I don't think it necessarily has to be face-to-face. I think what matters, you will certainly, if it's not having that interaction, you can automate some of the things you just mentioned, and that would help us have people be able to do other jobs in a U.S. healthcare system that's hurting to find enough labor. And you can connect and get those benefits from the patients. You don't get the benefit yourself if you're not connecting with patients, but certainly I think there's ways that you can have technology be, a connector. I mean, look at social media, right? Social media has a way for us to stay connected to people, but it also has sort of a dark side where maybe we perceive we're staying connected to people, but sometimes people can feel actually more lonely. Remember, loneliness, and this is something that the Surgeon General talks about now. He wrote a book on it, but loneliness, being lonely, is the equivalent to smoking a pack a day. So wow. Loneliness kills because that connection to people matters. The longest running study in existence, as far as I know, is the Harvard study of adult development. It's been going on for over 80 years. And what they did is they followed 268 Harvard sophomores years ago, 80 some years ago. In fact, one of them ended up being John F. Kennedy. He didn't at the time, he was, you wouldn't know what would happen to him later in life. So they followed these 268 Harvard sophomores, all men, because at that time, that's all they had at Harvard, and a matching cohort from Boston. And then they would evaluate them every year or so, and they would do physical tests and medical tests and psychological testing. And what they wanted to find was what was most likely to make them be happy and healthy and alive when they're older. And what they found was the biggest predictor in their 50s that they would be alive and happy and healthy in their 80s wasn't what medical conditions they had. It wasn't their socioeconomic background. It wasn't whether they went to Harvard. It wasn't whether they had diabetes or hypertension. The biggest predictor of whether they would be alive and happy and healthy in their 80s when they were 50 was how satisfied they were in the connections around them, in their relationships. Doesn't mean they have to have a spouse, overall relationships. So these connecting with people matters. And that's why you see all the benefits in the things we just talked about.
Wow. That's quite a statistic too, by the way, in terms of loneliness is like a pack of cigarettes, because that kind of is something people can probably relate to. I think we're at a point where we're going to hand it back to Mark in just a second, but I just want to recap the fact that, we started out really talking about these big challenges, and there are many of them, and there have been, and things are kind of facing us where it's really, really difficult. I think as we went through it, we talked both about technology and other things that can really sort of make that breakthrough change. And we definitely kind of concluded at a very hopeful point of kind of talking a bit about how this can all work and solve all those points of lower cost, higher quality, better experiences, better satisfaction in jobs, better access to care. So I think it overall is a very it's a very hopeful message, I think, as we went through that. So with that, I am going to have Mark come back on, and he's going to navigate our Q&A time for us.
I have magically reappeared. It's the joy of technology. That was such a fabulous discussion, Dr. Mazzarelli and Diana Knoll. I learned a lot, and it was really, really interesting, genuinely interesting for me. Let me first, ask one question, if I may. When you look at the beginning of your discussion, Dr. Mazzarelli, you talked about this huge problem with labor shortages, especially among clinicians, that we all know about, and I appreciated your comments. Do you think overall, when you look at the financial situation that hospitals, medical groups, and health systems are in right now, for our magazine, I track Kaufman Hall's quarterly reports, and where hospitals went from average nationwide revenue margins of minus 1.3 the last few quarters. Now they're at 0, which is still not good. 0 is still not good. What is your sense of when you think that hospital-based organizations will regain some greater financial stability and will be a little bit more okay overall?
It's a great question. I think, I also see those Kaufman Hall reports, and what's striking to me is that last year was the first year where our industry was as a whole negative. The margins for health systems were negative. I think it was around 2, a little over 2%. That means last year was financially the worst year in the history of health systems when it comes to financial performance, right? And so, yeah, we're clawing our way back up as volumes return, as the labor costs kind of come down a bit. But we're not going to be able to be innovative and serve patients and be our best selves at 0% and 0% margin either, right? We need a margin. I mean, in the nonprofit healthcare sector, which is most of healthcare, we make money for one reason: to spend it to improve things for ourselves, our team members, in particular, and our patients, right? We spend money on ourselves as a health system. And that's what we need that margin for. If you think about health systems and all the care, how they provide to everybody, we say a lot: no margin, no mission. So in order to meet our missions, I think you'll start to see it come back a bit. But I think that there's still a lot of work to be done, because even though we may have some of the bloat of these labor expenses there's still going to be a shortage of people. More people retired than we had expected during COVID, and there's less people in the pipeline. And now there's more jobs that people can do that are somewhat more attractive because they can work remotely. So, and there's also a general feeling now, this idea of YOLO, right? Like, you only live once. Like, I want to do a job that I care about, that's purposeful, that has meaning. So as healthcare, we need to frame this for people that's us, right? If you want to have purpose and you want to have meaning, we're the right kind of job to have in healthcare because of the tremendous privilege we have of taking care of people at their weakest and at their most frail moments.
Yeah. First of all, I totally agree with you, Dr. Mazzarelli. One thing that you alluded to slightly or obliquely was one thing that happened during the pandemic that was will potentially be quite devastating is, for the first time, we found out that large numbers of younger nurses, or nurses not in practice as long, were leaving. We've relied as a health system for decades and decades now on the idea that nurses, who are fabulous people, right? I think we can all stipulate to that. Historically, a nurse would get her or his degree, nursing degree, and start practice maybe in their mid-20s or somewhere around there, and would continue for 30, 40 years, and then they would retire. For the first time during the pandemic, we saw nurses in practice only a short while leaving. Well, that's going to leave a big hole, right? Because those nurses, if those nurses were only 35 and were only in practice for 10 years, and a whole bunch of them left, there will be, things will go down a little bit in a few years. Are you at all worried about the long-term nursing shortage per, as I said, the fact that some younger or nurses in practice a shorter time are leaving?
When it comes to labor, I'm worried about everything. It would be naive not to be. I think it's a twofold issue, right? It's not only are younger nurses now leaving sooner, but older nurses are retiring earlier. Right. So it's a crunch on both sides. Right. And I think this goes back to everything we've talked about for, the last 45 minutes, which is we have to have people really enjoy and be engaged in the job of being a nurse. Right. So it's because by the nature of what you're saying, we're getting there in the first place. Right. But so that's where we can take away the administrative burden. If we can have them connect with patients more, then I think we can have people stick around in a job where they actually see the purpose in what they're doing. They understand the value in what they're doing. And that becomes something that is, something they value that makes them want to stay. right? That we want to be, if people are leaving, if younger people are leaving jobs to go where they want to have purpose and feel like they have meaning, that needs to be us.
Yeah, absolutely. Let me check for more questions here. So another question, Dr. Mazzarelli, is when you look at where we are now with health IT, and it is wonderful that we have solutions like DAX that are really transforming physicians' work lives. What do you think about the fact that health IT leaders, our CIOs, CMIOs, et cetera, both clinician informaticists and general informaticists, they're almost feeling overwhelmed now. There's so much to do. And on the one hand, we've got all these new positions, chief data analytics officer, chief transformation officer, chief innovation officer. I even interviewed someone who was a chief quality officer or chief value officer, who is a liaison between the value-based contracting people and the clinician leaders, which is really interesting, a chief value officer.
We have a similar position.
Oh, you do? Okay, great,
do.
great. But how do we make sure that the people holding down the fort in health IT either don't leave or as you mentioned, they could go into other businesses, or they could go over to vendors, and they're nice vendors, obviously, good vendors. But how do you see that creating job satisfaction for health IT leaders also, so that, because they really are telling us they're getting crunched more and more now?
Yeah, I expect they will continue to get crunched because more and more everything is technology based, right? So there's almost nothing we do that doesn't affect information technology. I think that health systems have to think of IT in two different ways. It's, okay, I have a certain amount of IT that my IT department is about making IT run correctly. But then IT is also strategic. It is a strategy, and it is where you're putting your investments. And there's almost nothing that doesn't touch IT. And that's why I think there's an incredible role for IT and an incredible role for informatics. I look at informaticians, particularly clinical informaticists, as what we were saying before, workflow experts. Technology is just one piece that they do in that workflow. And now the idea of, hey, how do you hold on to IT people and informatics people when they can get paid more to go out to the vendors? That's the same competition we have for people not working in agency or people not working for consulting companies. We have to give them that purpose. You could tell other people how to do things, or you can help people do things that you can directly tie to your engagement that is helping patients and helping those who see patients. And I think that there's, something to be said about that. But, it's going to get harder and harder, right? Because there's more money out there to do these other things. But what we're hearing people say is that more important than money, not that money doesn't matter, because it does, but that 5 and 6 times more important is people feeling like they like what they do, people feeling like they're making a difference, people feeling purpose. And so that's what we have to make sure all of us manage and really focus on people.
Absolutely. And one more question, and then I'll turn it back to you and Diana to kind of summarize thoughts, because you've all said such great things here. You were talking about AI and its tremendous potential. When you look at it, and I thought you articulated it beautifully, are you at all concerned about some of the cybersecurity dangers of AI coming into healthcare? I just posted a thought piece, a blog by someone who has been a leader in cybersecurity in healthcare for years, Mac McMillan, and he talks about how he totally supports that there should be AI used for a lot of purposes in healthcare, but he is worried because, already we're, like you could get a message and it could be someone saying, "I'm Diana," and please send me $3 million or, whatever. And there are scary aspects to it. Do you
Wait,
worry at all?
So if Diana asked you to send her $3 million, would you do it? I'm just curious of your relationship,
I would
because
do
that's
No,
unbelievable.
just kidding.
I'm going to text you for $3 million, but
Well,
that's fantastic.
Well, I will tell you one thing, Doctor. There was Mac McMillan actually told me this story. One of the things that's already happening in cyber, and this isn't even AI, but he was consulting with a hospital system where this the criminals go in and they are able to get credentials, so that so we think they're Diana or we think they're someone else.
Yeah, that's the phishing scams. Yeah,
right. And so the CIO or a CFO was out of town and emailed one of his top people saying, I need you to send, move funds into this account, right?
Yeah.
And the person believed the not real CFO. So as we get more into that, could there be a danger, including in some clinical areas where there might be criminals who might want to make mischief?
Of course. If there's money,
Yes.
the criminals will want to get mischief. I mean, we could end all AI tomorrow, and the situation you just said still exists, right? Like so there's always a risk with technology. I mean, we'd be naive not to think about it. We have to make sure we put those controls in, but we've figured this out for a lot of technology as long as we make sure we think about it. People thought that having calculators would mean people will never know how to do math. Right, like that's the end of people, and we now we even have new math. We know how to do math so well, right? Like that. So it doesn't usually play out that way, right? That like I was saying before, that we don't need the car, we just need a faster horse and buggy, right? And look what the car has done for all of us. So I do think we have to think about those downsides, right? But this idea that Skynet will turn the computers against us, I think is a little bit of hyperbole. I get that it's total catnip for those that write blogs and do media to think of the doomsday scenario. I mean, I could ask GPT-4 right now, tell me why you shouldn't go to the hospital when you're having an acute heart attack. And it'll give me several paragraphs, right? Like that doesn't mean it's a bad technology, right? A scalpel can be used at a murder scene, but yet it's a tool, right? So we have to... I'm not ignoring those issues. We have to think about those issues. I'm just saying we have a track record of being able to figure those out, right? So people have been sort of predicting the end of days based on whatever the newest technology is for centuries. And generally, we're able to find a way to tame it. But it doesn't mean we don't have to think about it. We do have to think about it.
Yeah. And to your point, Doctor, one of the most interesting things that has happened in the last 2 decades, I remember interviewing a well-known physician. He's both a physician and medical informaticist, and he practiced at Palo Alto Medical Foundation. And of course, he said, more than half of my patients are either faculty at Stanford, family of faculty, or students. They're highly educated people, and they're bringing in reams of things. Now they're probably doing it on their phones, saying, I read, like the layperson, I read a New England Journal of Medicine article yesterday, and it said blah, blah, blah. So we had to get over that. And it feels as though, as a system, we have that initial feeling of culture shock for clinicians. As patients, we're able to use the consumer web, right? And of course, diagnose amazing things for themselves. And then you go into the physician and she or he says, well, actually, you're completely wrong there. So we have had to overcome those.
Sure, but I think for the most part, I think, I don't think we'd say, hey, it'd be better, a completely uneducated about healthcare population that we block from ever learning about medicine on the internet. Like, I don't think we'd want that, right? So certainly it certainly is a change for us as physicians. We can all think of the stories where, it kind of adds to our plate to have those discussions. But at the end of the day, we'll find that rhythm. I actually hear that a lot less now than I did 5 years ago, right?
I think that's right, yeah.
So we're kind of getting better at that. But I certainly think there is a rise in consumerism. And that people are going to control their own fate when it comes to healthcare, and that there's going to be a lot more we have to do to treat patients also as consumers.
Right, and the medical culture is changing as the society changes. One tiny note. I had the blessing of growing up with much older parents, and my grandmother lived with us, and she was born in 1888, and so she would
What?
tell, she was born, and she lived to be almost 100, and in her day, the 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 patient would go to the physician, and the physician would say, and my grandmother's name was Alma Fenner, Mrs. Fenner, take the blue pill. And she would never question that. But the reality is now, patients are different. And so it's a dialogue, isn't it?
Yeah, it's a dialogue. And, when she was younger, there were only 2 pills, right? Now there's dozens of pills.
Right.
Right. So
exactly,
that's also a big difference as well.
Right. And there was no direct to consumer advertising on TV because there was no TV. So we just have a couple of minutes. I would just like to throw it back to you, Dr. Mazzarelli, and Diana, closing thoughts as we move forward into the future. Anything that you'd like to share with our audience? We have about 3 minutes left.
Well, let me start. By the way, I think we are at a different point. We started out at the beginning of this talking about the major challenges. So I think we all accept the fact that we have to do something different, and technology can help us with that. I think I've also lived through it. Like when we first talked about DAX, we said, will patients consent to it? But patients can see the benefit of it. Physicians see the benefit of it. And even with any kind of AI, a doctor reminded me, said, Diana, it doesn't have to be perfect. It does have to have backstops here. We always take the responsibility for the care, but it can help us be better. And we have to look for the areas where it can help us be better, because we're humans and we make mistakes. So, AI is getting trained by humans that are making mistakes. So I think it's kind of the full circle aspect of where we're at right now. I found it very interesting in terms of the dialogue of talking about where the challenges are, but where are the opportunities. I would just pass it back to you, Dr. Mazzarelli. You have been in this space. You're the best to say, where are your thoughts right now? How hopeful are you? Leave our audience with those sort of, top of things that you're most hopeful about at this point.
Yeah, I'll say it's really several things. So I'm optimistic that the application of AI, generative AI, will improve medical care, facilitate those ethical decision-making discussions we need to have, and ultimately strengthen the bond between doctors and patients, those who provide care, anyone who provides care, and those that receive it. And that ultimately is going to improve outcomes, lower costs, and keep people practicing in the medical field.
Wonderful. Wonderful.
Well said.
Thank you so much, Dr. Mazzarelli. Thank you so much, and thank you, Diana. This has been a wonderful discussion. I know I've learned a lot, and I'm sure that our audience has. So I'll close it off now. We have a minute left. I'll just say, unfortunately, that's all the time we have for today. I'd like to thank both Dr. Mazzarelli and Diana for today's wonderful webinar discussion. And I'd like to thank our friends at Nuance for making today's program possible. Finally, I'd like to thank everyone in our audience for joining us. We hope you'll join us again in the future for another Healthcare Innovation webinar. This concludes today's presentation. Have a great day, everyone. Thank you.